Continuing the journey to improve the success of IVF, after the pickup, there are certain rules or certain precautions that the patient or the couple need to follow so that the success is ensured. As I already mentioned, that we prefer to do frozen embryo transfer to most of them unless we have certain indications to do a fresh embryo transfer. Frozen embryo transfer can be done anytime after the pickup, maybe the next cycle or next to next cycle, or couple wants to take a break for 3-4 months, they can definitely take a break. See, why this is encouraged is, as we have been stressing from the beginning, that stress plays a huge role in the positivity of the results. Taking 1 or 2 months break is always helpful for their mental status. They can go for a travel or plan their holidays, because once they conceive, again it's a journey which takes 9 months till delivery and then the baby. So again that life becomes very, very strenuous. So we encourage the patients to take this 1 or 2 months break, which is helpful. During this 1 or 2 months break, there are certain things which we do. Ideally, to start the process of frozen embryo transfer, we call our patient back on day 2nd or 3rd of a period. We do a scan, see if there is any signs of infection or cyst or any other reasons where we feel that it can affect the chances of success. Then we put them on certain hormones, or we can also go on what is called as a natural cycle FET, or we can go on estrogen tablets for frozen embryo transfer. Ultimately, the success of the IVF comes down to 3 major factors. One is the embryo, next is the uterus or the endometrial lining and the health of the mother herself, and third, though not very significant, is the way the embryo transfer has been done. Embryo is graded depending upon the way it appears, the uniformity of the cells, expansion of the embryo, and if there is any fragmentations, vacuoles, all those things are assessed, and they're graded as far as we do only day 5 transfers, so it will be grade A blast, grade AA blast, or AB blast. So these are the grading system. Next comes the endometrium. As I said, we generally believe in doing frozen embryo transfer. We try to prepare the endometrium, try to target a certain level of thickness of endometrium. It is considered that the endometrium is best if the thickness is between 8 to 11 mm. The blood flow should be good. We try to do power Doppler studies of the endometrium so that the blood flow is at least present in zone 3 and zone 4 of the lining of the endometrium. We study the blood flow resistance in the uterine arteries, and when all this is perfect, and when all these criteria are met, we check the progesterone value and then give them progesterone tablets and injections to do day 5, that is 120 hours of the embryo transfer. We are very strict on the timing of the embryo transfer. In my experience, we have seen that 120 hours with the day 5 transfer has given us the very good results as compared to any other timings. The next important factor is the way the embryo transfer is done. Embryo transfer should be done very smoothly without having any bleeding and pain to the patient. Sometimes it may get difficult. To ensure that it doesn't become difficult, we in IKEA follow one particular rule. During the pickup, as the patient is under anesthesia, we assess the uterocervical length and the direction so that we are sure how we can pass the embryo transfer catheter. To make sure that the embryo transfer is very smooth, we in IKEA during the OM pickup itself assess the uterocervical length and the direction. As the patient is already under anesthesia, we utilize this benefit and do what is called as a mock transfer. We use the embryo transfer catheter and measure the direction and the distance of the uterocervical length. Thus, this process helps us in making sure that the embryo transfer goes very smooth and bloodless and painless.